Hi, everybody. I would like to welcome you all to this special webinar by the International Academy for Clinical Hematology. This is unfortunately a very special crisis we are facing worldwide, and the medical community is united everywhere to fight and get rid of this novel coronavirus and all the harm it's causing around the globe. And as you know, the hematology patient are a specific population which is at higher risk for infections in general, especially opportunistic infections. And we know the outcome of these patients can be really very dismal if they get infections like the COVID-19, for which we do not have any special or specific therapy beside confinement and the social distanciation measures. We have done, the Academy has performed a first special debate about COVID-19 and hematologic malignancies in general a few days ago. But following this first webinar, we received dozens of questions which are specific to actually myeloma. And this is the reason the executive committee thought that we need to have a special webinar dedicated to multiple myeloma. And I'm extremely grateful to Professor Marie-V. Mateos from Salamanca in Spain, who accepted to join me into this webinar and try together to provide some guidance to our colleagues based on some very frequently asked questions. So thank you, Professor Mateos, for joining. Before going into the details of the different questions, I would like to highlight that this is really a very rapidly moving field, and all of this is based on empirical data, common sense, experience from colleagues, and experience from management of severe infections in hematologic patient. So I hope all of this will be helpful to the community. My first question to you, Marie-V, is about why do you believe myeloma patients are at a higher risk for a COVID-19 infection?
Thanks, Mohammed, and thanks for this excellent initiative, because although based on more or less recommendation, I think that these tips are going to be of great help for physicians treating patients with multiple myeloma. Definitely, I think that there are several risk factors that can potentially explain why our myeloma patients are at higher risk for COVID-19 infections. Myeloma-related factors, patient-related factors, and treatment-related factors. The disease itself, we know that this is an immunocompromised disease, and we know that the environment of multiple myeloma is basically based in an immunosuppressed environment. Why? Because we know that the T-cell responses are usually impaired. We know that the B-cell numbers are usually also reduced. And well, definitely we know that there is recruitment of immunosuppressive cells like Tregs, Bregs, myeloid-derived suppressor cells in the bone marrow. So definitely myeloma is an immunosuppressive disease. But in addition, I think that there are also patient-related factors. So we know that myeloma usually affects to the elderly population, and the immune system is also much more compromised. In addition, this population usually present with comorbidities like cardiovascular disease, diabetes, and so on. And finally, and I think that is also important, the treatment-related factors. When the disease is active, we usually use for the therapy of our myeloma patients combination based on proteasome inhibitor, immunomodulatory drugs, but also corticosteroids. And I think that these combinations, when the disease is active, is going also to contribute to higher risk for COVID-19 infections. We can't forget also the cytopenias that some of these regimes usually induce. So definitely, I think that these three factors can potentially explain the higher risk.
Yeah, absolutely. I think multiple myeloma patients are really indeed a very good example of highly immunosuppressed patient. And I think we all agree in the community that during this severe pandemic, we would like to protect such highly immunosuppressed patient against the COVID-19 infection, because based on data from China, Italy, and elsewhere, we know very well in general that cancer patient, and there are publications in this direction, these patients have a higher risk. The hazard ratio is between 3 to 5 of developing severe complications and a higher risk of death after COVID-19. But at the same time, I think we also all agree that we would like to maintain a high standard of myeloma care during this pandemic, because obviously the disease by itself, myeloma, doesn't care about the coronavirus, and it has its own natural history. And this is why we would like to give some tips on how to maintain such high standard. And obviously, I think we would like to protect the healthcare professionals, because if you are able to protect the workforce, then you are able to fight against COVID-19, and you are able to protect, to continue to treat the patient very well. So my second question to you, Marie-V, is about autotransplant, because we know very well that autologous hematopoietic cell transplantation frontline is really the standard of care, whether for the standard risk or the high-risk patient. And as you mentioned, this is not an easy procedure, and given the circumstances, do you think we should postpone autotransplant? And if yes, what are the alternatives to maintain or to avoid any loss of chance for our patients?
Yeah, this is an excellent question, and I totally agree with your comment that I think that is relevant. We have to try to preserve our patients from the COVID-19 infections, but we can't forget that myeloma can potentially kill to our patients. So in this pandemic situation, we have to try to our patients with the disease under control, and we have to try to individualize and to optimize all options of therapy we have in order to maintain our patients under control. Because, well, the active disease can be one additional problem if the patients become COVID-19 positive. Concerning the specific question about the role of autologous stem cell transplantation, I think that the situation is very dynamic, and the situation is changing country by country. But in general, I would say that today we don't need to expose to our myeloma patients to high dose melphalan, a myeloablative conditioning regime with some weeks with severe cytopenia, and definitely another extremely high risk for COVID-19. And I think that if there would not be any other alternative, because the patient would be at high risk and the transplant is already planned, and in your institution there is not any problem to go forward with the autologous stem cell transplantation, I would recommend you to test the patient for COVID-19 before starting the conditioning regime. But if it would be possible to delay the transplant, this would be my recommendation. And it is possible, and we can discuss later on, but it is possible to prolong the induction. And if you decide to utilize bortezomib lenalidomide and dexamethasone, or bortezomib thalidomide, or bortezomib cyclophosphamide and dexamethasone, to extend the induction period until maximal response is achieved, or until a plateau phase is observed, and directly to move to maintenance therapy. So I would give a clear message. We have to try to maintain the disease under control with the option of therapy safer for the patients.
Yeah, and I think there is now a more and more well-established consensus from different experts worldwide, highlighting that definitely we need to postpone the auto-transplant procedure. And by the way, we also know from our randomized trials in general, the European trials, the IFM trials, that in all cases, the difference between auto and non-auto is mainly about progression-free survival, but there is no overall survival difference. And in the IFM 2009 trial, actually those patients who received 8 cycles of VRD had the same survival compared to the patient who received VRD induction and auto transplant followed by maintenance. So definitely I think it would be wise to postpone the auto transplant procedure, because we do have a good alternative, and there would be probably no harm to the patient. But some colleagues, Marie-V, would be worried maybe about stem cell mobilization if they do more cycles of induction. Is this something worrying for you? Because I thought that with plerixafor we can collect almost everybody in any circumstance.
Yeah, so I think that it depends center by center, because if the apheresis unit would be available to collect peripheral blood stem cells, okay, do it. My recommendation, again, please test for COVID-19 your patients before to proceed to the peripheral stem cell collection. And I would recommend not to utilize cyclophosphamide as mobilizer, and to mobilize your patient just with G-CSF in order to avoid the risk for COVID-19 infections. But again, in my center, for example, the apheresis unit is closed for peripheral blood stem cell collection right now. And well, according with your comment, we have decided to extend the induction therapy. There are couple of trials, the French study, the European Myeloma Network trial, showing how if patients do not receive a transplant in first line, the survival is going to be equivalent. And I think that this would be much more confident if your patient is RISS1, and in addition, if the patient achieves complete response or even minimal residual disease negative. So I think that from my point of view, it would be better not to proceed to the stem cell mobilization if it is not required, and to wait, because as you mentioned, it could be possible to do at the moment of the relapse utilizing plerixafor or other mobilizer agents.
Yeah, I think definitely the wait and watch attitude is very important, because even if the apheresis facility is open, we would like to decrease or avoid the circulation of the patient, and we would like to avoid them coming to the hospital, because we should not forget, and this is not specific to our patient, that this virus doesn't circulate alone. It doesn't have its own car, or it doesn't fly in the air. It's actually circulated by people like you and me, and the patient are really very important transmitters and carriers of the virus. So apheresis session would require patient to come several times sometimes. So we would like really to avoid this.
Yeah.
Okay, so we postpone the auto. We try to avoid the stem cell collection because there is no harm. Let's move now to those patients, and we receive a lot of anxious calls and emails and letters from patients who are post-auto receiving maintenance therapy, let's say lenalidomide or bortezomib for some subgroups. What should be our attitude in these patients? And let me start, for instance, with the patient who is already in complete remission or VGPR. What do you think?
Well, my personal recommendation right now is the patients to continue on maintenance with the lenalidomide, because lenalidomide single agent at a low dose, the effect that we are looking for is an immunomodulatory effect, is not an anti-tumor effect, because this effect was achieved previously. So what we are doing is to continue with the lenalidomide maintenance. One of the main reasons is because we have to consider this pandemic situation like a bridging period in which we have to maintain the patients with the disease under control. And I think that is extremely important to maintain the response previously achieved. And I think that lenalidomide as maintenance can reach this goal, as it has been demonstrated in many trials. Of course, we have to try to deliver the treatment at home, and this is what we are doing. Patients are not coming to the hospital to collect the medication, but the medication is being delivered at home for a couple of months instead of just 1 month, and we are doing phone visits in order to monitor tolerability and so on. In which patient I should potentially stop maintenance with lenalidomide? Again, patients in which lenalidomide is not being very well tolerated, especially from the hematological point of view, and if the patient has previously developed infections. So in these patients, maybe it would be prudent to try to stop maintenance during this pandemic situation. But for most patients, my recommendation would be to continue with lenalidomide single agent, no dexamethasone.
Yeah,
If the patient... No, go ahead, Mohammed.
No, absolutely. I think we also need to highlight this general rule to all patients to avoid stopping spontaneously the therapy. I think if there are fears, anxiety, whatever concerns, this needs to be discussed with the attending physician, because obviously it's always about the balance between the risk of the infection and the myeloma disease control. And we would like to avoid, as highlighted in the introduction, that there is a loss of efficacy in terms of myeloma control because of our concern about the risk of infection. Any thoughts, Marie-V, outside the transplant setting, those elderly patients receiving therapy over the long term, and we know that the dogma now is to give continuous therapy?
Well, I would say the same attitude. Of course, if the elderly patients would be receiving lenalidomide and dexamethasone, I would stop dexamethasone as first step, and a second step, I would try also to reduce the dose of lenalidomide. And again, I think that there is, well, an individualization of the therapy patient by patient, putting in a balance the benefit and the risk. And well, if the patient has just finished, imagine the first 9 cycles with len plus low dose dexamethasone, well, maybe if you discontinue immediately lenalidomide, the disease can potentially evolve again very soon. So I would give the same concept. I would try to maintain the patients on treatment with lenalidomide, single agent, without dexamethasone, and of course, I would try to stop in patients at extremely high risk for COVID-19 infection.
So that brings me to the question about frontline therapy, because unfortunately, despite the pandemic, actually every week we have a new patient, a diagnosis coming, myeloma, lymphoma, leukemia, and so on. So for these patients, if they are transplant eligible, we would agree that their frontline therapy should be the classical induction used by people like VRD, VCD, or VTD. Would you agree on this?
Yes, I basically agree. Of course, we have to evaluate carefully patient by patient, but I would say that the answer is yes. Of course, bortezomib is going to take part of whatever three drug-based combination we utilize, VRD, VTD, or CyBorD, and we have to try to optimize the bortezomib administration. Sub-Q is the standard of care, but I would move to the weekly administration, and I would try to individualize the bortezomib delivery. There are some countries in which it is possible to deliver bortezomib at home. This would be, of course, the ideal situation. If this would not be the case, my recommendation would be the patient to stay at the hospital as less as possible. So maybe the patient can potentially call to the nurse when the patient is going to go out from home. The patient can potentially wait in the car until the drug is ready to be delivered. And I think that we have to try to optimize the stay of the patients at the hospital, because we know that now the hospitals are places at a higher risk of becoming COVID-19 positive.
Yeah, so absolutely. We remain with the same philosophy, the minimum visit to the hospital. And if you have to come to the hospital, then it should be for a minimalistic duration. And I would like also to emphasize what you mentioned is that pharmacists are requested and have been authorized in many countries now to deliver drugs for at least 2 months. And I'm specifically thinking about the IMiDs, because there is a lot of concern usually about IMiDs, and they are very highly regulated in terms of number of pills and duration. But in these special circumstances, I think we need to be a little bit more liberal in our approach. That brings me, Marie-V, because you mentioned the different therapies, and we may wish to avoid the hospital, go to oral approaches, and so on. But all of our regimens include, whether in the young or elderly, frontline or relapse setting, all of our regimens include dexamethasone. And outside the COVID-19 infection, I mean, we know very well that dexamethasone is a risk factor for infections. And now, in the COVID-19 infection, in the general population outside myeloma, it is now more and more established that steroids in general, I didn't see data about dexamethasone, but steroids in general are really a major risk factor for morbidity and mortality if you get COVID-19. So what should be our approach to dexamethasone dosage in the myeloma population?
Well, the first recommendation would be to utilize the dexamethasone according to your comment only in patients in which we consider that it is absolutely necessary. Once we have said this, I would try to utilize the lower dose as possible. And definitely 40 milligrams weekly will be the highest dose to be utilized, but ideally 20 or even 10 milligrams just once per week. We have to try to maintain the anti-tumor activity and the synergistic effect with IMiDs and proteasome inhibitors, but as our patients are at higher risk, we have to try to utilize the lowest dose as possible.
Yeah, I can confirm. We started already reducing by 50% all our dexamethasone dosage. And to be honest, in those patients who are in response and are already, you know, at a later stage, I would say we are skipping it, because I don't believe there will be a big harm if you skip it for 1 month and wait and see. Obviously, if the pandemic is going to last for a longer period, then we have to rethink all of our approaches. But definitely, we would like the colleagues to pay attention to dexamethasone, try to avoid it whenever possible, or really use the minimalistic dose.
Absolutely.
We have other questions about biphosphonate, zoledronic acid. You know, these patients used to come from time to time, like on a monthly basis, to the day hospital and so on. Would you agree, Marie-V, that this should be stopped for the moment, and this will not lead to any negative outcome for the patient?
Absolutely. Well, bisphosphonates has taken part of supportive therapy. The only exception would be the presence of hypercalcemia. And in these situations, patients would be admitted to the hospital and maybe bisphosphonates would be required. But for the rest of the patients, I completely agree with you that we can avoid bisphosphonates until the pandemic COVID-19 situation recovers.
Before going into the prophylactic measures, I would like to also, so we spoke about dexamethasone, we spoke about biphosphonate drugs and so on. Do you see also a way to increase the length of a cycle? I'm thinking about those patients receiving antibodies, like anti-CD38 antibodies. If they are really have been receiving them for long periods, can we try, because again, we want to gain some time during the pandemic, can we extend the duration of the cycles instead of every 4 weeks to go to 5 weeks? I mean, from a pharmacologic point of view, I don't see an obstacle. What do you think?
No, I completely agree. And in fact, this is what we usually do, or at least I do in some patients in the long-term follow-up, because, well, they prefer to have at least 2 weeks without any medication. And I prolong the duration of the cycles to 5 weeks instead of 4. So I think that this is completely appropriate. And also from the general point of view, when the situation is becoming much more chaotic, I would say, in the hospitals, and this has actually occurred in our hospital last week, we decided to convert the 3 drug-based combination at relapse in patients with the disease under control in just 2 drug-based combination. And we decided to eliminate the monoclonal antibody or carfilzomib in order to the patients receive only lenalidomide and low-dose dexamethasone, or only lenalidomide for a while. According to your comment, if the pandemic situation would prolong, well, we have to reconsider the situation. But in principle, in order to protect our patients from visits to the hospitals, and due to the fact that the anti-CD38 monoclonal antibodies required or long stay at the hospital, we decided to stop their administration. But definitely, I agree with the duration of the cycles, 5 or 6 weeks instead of the conventional 4 weeks.
So you mentioned switching from triplet to doublets. So what do you think about in case we want to use a proteasome inhibitor? Do you see a role for ixazomib, which is an oral proteasome inhibitor, 1 pill per week? I believe it can be an attractive option in many patients.
Absolutely, absolutely. I'm sorry because I didn't mention, because unfortunately in the country, in Spain, ixazomib is not approved for myeloma patients, although it's true that we have a compassionate use program. So if there are physicians from Spain, I think that they have to pay their attention to this fact, and it is possible to ask for ixazomib, and according to your comment, it's an ideal situation. Another possibility, and I think that physicians should not forget, cyclophosphamide, 50 milligrams every other day. Well, cyclophosphamide has even an immunomodulatory effect and can be also an ideal partner for lenalidomide or pomalidomide to deliver to our patients 3 drug-based combinations.
And by the way, this is evidence-based. I mean, we have a trial testing PCD, pomalidomide, cyclophosphamide, dexamethasone, and it works very well. You have trials RCD, lenalidomide, cyclophosphamide, dexamethasone, and there is a small phase 2 trial, I think, with ixazomib, cyclophosphamide, dexamethasone. And I agree with you that the situation can be different between places regarding approvals and so on. But I'm confident that the regulators, the authorities, the pharma companies are going, everybody's united hand in hand to try to facilitate things. And I'm confident that whenever it can help the patient, all of these stakeholders will do an effort and allow access to drugs. So patients are asking us frequently, beside, hand washing, which is very important, by the way, beside social distancing and confinement, are there any drugs that can allow myeloma patient to avoid COVID-19? For example, immunoglobulins. I mean, I don't believe they can work, otherwise it would have been very easy to fight this infection, but can we clearly say that we don't have much measures, unfortunately?
Yeah, I think, and there is not any formal recommendation to the utilization of immunoglobulins, as you mentioned. There is not any evidence-based, and in fact, immunoglobulins administration required visits to the hospital. So I think that it would be better to stay at home as much as possible. And well, I think that physicians have to alert to the patients about the package delivery, and they have to try to avoid contact with the persons that are coming out of the home. They have to realize that the coronavirus can survive in some surfaces, so they have to take care about that. And well, what you mentioned, washing hands, and of course social distance. Try to avoid the contact even with the family if there is someone positive. One recommendation also, before, if the patients have to visit the hospital because they have to receive a medication, the day before we call to all patients in order to check that they don't have any respiratory symptomatology, they don't have, and also their families. And it's important because if they present with any symptomatology, well, they have to go by a different way, COVID-19 positive way, but it is very important these patients can be within the safe hematology space in which we protect our patients COVID-19 negative.
So that brings me, Marie-V, to the question, and unfortunately we had a few patients like this. They are being treated for their myeloma, and like many people in the general population, they get the COVID-19 infection, and we already lost patient, unfortunately. So do you feel comfortable that during this COVID-19 infection, even if there are only mild symptoms and people are only requested to stay at home and I would say, wait if there is no aggravation of the symptoms. Would you agree that we should put on hold all therapy and allow them to recover easily?
Absolutely. We don't have any other evidence, and this is what we have to do, and to carefully monitor these patients, but through the COVID-19 positive way, not by the conventional hematology way, because we have to preserve again to our patients. And if the myeloma patient has to be admitted to the hospital, the patient should be admitted within the COVID-19 positive area. And the ideal situation would be to manage this patient by a multidisciplinary team involving internal medicine doctors together with hematologists, but myeloma therapy should be stopped definitely.
So I guess you mentioned multidisciplinary teams and meetings. I guess everything now in the hospital is being done by WebEx, exactly like we're doing this webinar, and we're learning of new ways of managing and interacting with each other. I would like, before the conclusion, to highlight the issue of clinical trials and protocols, because we know that the myeloma field is a very active field in terms of clinical research. The percentage of patients included in clinical trials is extremely high compared to other cancers or other diseases. And we know very well that these clinical research protocols also sometimes they allow to bring new, very important drug for patients who are in need, but they are usually the source of lots of circulation. You have data managers, you have technicians, you have monitors coming in and out. The patient have very frequent visits. The inclusion in a protocol takes a lot of times with lots of exams and tests, etc. So what has been your decision regarding clinical trials in your institution?
Well, sometimes we have to follow the guidelines coming from the different sponsors, and you know that some sponsors decided to put on hold the recruitment of new patients in their clinical trials. This is definitely what we have done in our institution, especially because we can ensure the safety of our patients. As you mentioned, patients have to frequently visit the hospital. The screening procedures require the visits to different departments, and I think that this is not the situation right now. This is not the risk that we have to run with our patients. We have to try to preserve them. We have to try to control the disease and to maintain it under control, like a bridging situation, and we will have the opportunity to recruit them in trials in the future. But I think that now is not the optimal time.
Yeah, but then I think it's very reasonable to assume that we have to put on hold these clinical trials because all the reasons we mentioned. But for those patients who are already included, I think sponsors also should understand that we may not be able to fulfill all of the requirements about these, recurrent visits, and they have to find different solutions. I know many of them are working hard. They are even delivering the drugs at home delivery of the drugs of the trial. So this is really very important. Would you agree, because some centers, including our center, for instance, we kept the trials which are allowing for a drug which doesn't exist commercially, and we know it may provide some hope or help for a patient who has no other choices. Would you endorse this?
Yes, of course. And if there is, as we have discussed during this meeting, we have to individualize patient by patient, and we have to put in the balance the benefit and the risk. And if there is not any other alternative for a young patient and you have a clinical trial active, of course you have to run the risk. And for example, in my hospital, a new patient will receive a new drug next week. But this is just special cases and cases discussed patient by patient.
Well, thank you very much, Dr. Mateos. That was a very important discussion with very helpful guidance and recommendations to our myeloma community, whether physicians or patients. I'd like to thank you all for your attention, and please do not hesitate to share your experiences or any tips you have that would allow to optimize the management of our patient, because at the end of the day, like in our introduction, the goal is to protect these highly immunosuppressed patients, to maintain the myeloma therapy and disease control, but also allow the health workforce to be always available to deliver a high standard of care to our patient. So with this, I'd like to thank you all for your attention, and I hope you are all safe and well, and please follow the guidance, follow the rules in your environment, because all together we will be able to overcome this serious, severe pandemic, and I'm sure there is a lot of light at the end of this tunnel. Thank you very much for your attention, and hope to see you all very soon, safe and well. Thank you.
Thank you.